Hello, my name is Mercy Clipo Miantona. I am a DNP candidate at Maryville University, and I'm presenting on my DNP project title, Evaluating the Impact of Stigma Screening on Treatment Adherence and Care Outcomes in Patients with Depression and Anxiety in an outpatient psychiatric clinic. I want to appreciate all my committee members. Thank you for impacting me and giving me the opportunity to learn and grow. Thank you so much. For background information, mental illness remains highly stigmatized despite the high global prevalence. Study shows that approximately 1 in 8 people worldwide live with a mental health disorder, and stigma can contribute to delay access of care, social isolation, worsening of psychiatric symptoms, and increased hospitalizations in these people. In an outpatient psychiatric settings, stigma can negatively impact provider-patient relationship, especially trusting relationship, medication adherence, and treatment outcomes. Study shows that stigma can reduce help-seeking behaviors, pointing the need for an urgent patient-centered care and stigma-informed sensitive clinical strategies. Self-stigma is a clinical problem. It is a major barrier to help-seeking behavior, and it can prevent these patients from seeking care in outpatient psychiatric clinics. Also, the lack of a formal self-stigma screening tool may lead to early discontinuation of care. These barriers can contribute to symptoms exacerbation, increased hospitalization, and financial burdens on these patients, their families, and the healthcare systems. For this reason, the purpose for my project was to evaluate the impact of a standardized stigma screening on treatment, adherence, and care outcomes. The focus of this project was on adults with depression and/or anxiety disorder in an outpatient psychiatric clinic. Lots of literature reviews have been done on this clinical problem, but it continues to show that mental health stigma is a persistent barrier to help-seeking behavior and adherence to care. The self-stigma is a type of stigma that involves shame, low self-esteem, and social isolation. And patients who struggle with this, with self-stigma, will stay away from getting care due to shame of what people will say or think about them. Discrimination, fears, and reduction in care engagement can also be from public stigma. Both stigmas are associated with poor clinical outcomes because they can reduce treatment adherence and have lots of negative psychosocial effects on these patients. It has been proven that self-stigma of seeking help skill is an evidence-based validated tool that can be used to assess self-stigma inpatient in and outpatient settings, which is why I use this tool as the primary tool to evaluate this patient for self-stigma. Study also shows that psychoeducation interventions can improve mental health literacy, health-seeking behavior, and treatment adherence. The frameworks that guided my quality improvement projects include health behavior model, which stated that perceived barriers can influence health behaviors. As you can see, self-stigma can prevent patients from seeking care. The Plan, Do, Study, Act framework also guided the implementation and evaluation of the interventions of this project. And lastly, the Iowa model of evidence-based practice supported the translation of the evidence of findings into the clinical practice. This project took place in an outpatient psychiatric clinic in western region of the country amongst adults 18 years and older diagnosed with depression and or anxiety. The total participant was 30 patients divided between the intervention group and non-intervention group. 15 patients was in the intervention group and 15 in the non-intervention group, which is the control group. The primary instrument used for this project was the self-stigma of seeking help skill. It is a validated self-reported tool with 10 items. The higher the scores, the greater level of self-stigma. This tool, the Stigma tool, was administered during the patient routine clinic visits, and it was administered only to those within the intervention group. The usual care group was the control group. They did not receive the Stigma tool or the psychoeducation. The result of the psychoeducation guided the initiation of a psychoeducation intervention. This gave the provider the opportunity to educate the patient on or provide supportive education on the importance of patient-trusted relationship, medication adherence, stigma and its negative effects, and validating the patient's emotions and feelings regarding the topic, and providing encouragement and reinforcement of adherence. Study shows that a standardized tool used in clinical practice, used in quality improvement projects can improve the trustworthiness of the project. Methods of evaluation. The retrospective child review was selected and it was used to extract data from the electronic record. It also compares The intervention group, which are those who received the stigma screening along with psychoeducation, to the usual care group, which is those who did not get any intervention other than their usual care. Data that were extracted from the electronic medical record included their diagnosis, medications, adherence record, and the patient follow-up visits. These data were de-identified prior to the analysis, and the analysis included descriptive and comparative statistics. The evaluation or the methods evaluation focused solely on the patient engagement in treatment, the patient medication adherence, and the treatment outcomes. How were they doing? These were things that were evaluated. This design was selected because it helps with the using of existing clinical record or data, and it is feasible for quality improvement projects. Also, it helps minimizes ethical concerns. For the project, a two proportional or proportion Z test was selected, and it was used for the sample size of 30 participants. The results showed that the intervention group had higher adherence to treatment rate of 93%, while the control group had adherence rate of 73%, giving an absolute risk difference of 20%, which shows that the intervention group had higher rate of adherence over the control group. The p-value was not statistically significant. However, the finding of the 93% or 20% and 20% showed a positive trend in treatment adherence favoring the intervention group. Descriptively and according to the graphic data, females demonstrated the non-intervention group, which is the control group, with 60%, while the male dominated the intervention group with 53.3%. In regards to race, the Caucasian dominated the intervention group with 46.7%, while the Asian dominated the non-intervention group with 53.3%. The descriptive statistics show that in the intervention group, the minimum age was 33 years old and the maximum was 63, while the non-intervention group showed the minimum age of 23 years old and maximum age of 68. The stigma screening severity levels show that 33.3% of the patients or the participants have mild level of self-stigma, and also show 40% of moderate level of self-stigma and 26.7% higher level of self-stigma. This shows that stigma, as you can see, the moderate and higher rate in these patients, they are. This tells that self-stigma is a barrier to seeking help and treatment adherence. This is why this tool was used to educate and encourage and reinforce the importance of treatment adherence using targeted psychoeducation. The project result was seen between the comparison of treatment between the comparison of treatment adherence between the intervention and non-intervention group. The adherence rate shows higher percentage of 93% in the intervention group and slightly low intervention rate of adherence rates of 73% in the control group, giving the total of 20% difference increased adherence rate favoring the intervention group. The p-value was statistically not significant. However, the increase in treatment adherence shows that with the use of a standardized Stigma tool in clinical settings, especially outpatient psychiatric settings, may improve patient adherence to treatments. The project was retrospective comparative chart review. It was done between two groups, the intervention and the usual care group, and it was a quality improvement initiative. The outcome shows increased adherence rates of 20% in the intervention group. It showed improved stigma-informed education between the patient and the provider, and enhanced patient-provider relationships. The strength of this project was the integration of a standardized Stigma tool into the clinic workflow, which helped increase patient awareness of stigma-related barriers and their impact on treatment outcomes. It helps to improve patient-centered communication and care, and improved patient and provider relationships, and the patient treatment adherence as well. Limitations and gaps seen during the project was, the gap was no routine stigma screening at the clinic prior to the initiation of the project. And also during the project, the small sample size reduced the statistical power of the project, and the use of retrospective design limited the control of data. Also, the short-term evaluation period limited long-term findings of the project. Overall, 20% higher continuation of care was seen in the intervention group, even though it was not statistically significant, but clinically it was meaningful and a positive way to improve patient adherence to care. Barriers seen was inconsistency initially with the workflow when trying to implement the Stigma tool, also the small sample size and the limited time. These were barriers noted during the project. And the benefits was the improved communication, the awareness, patient awareness of stigma and its negative impacts on treatment, and the patient adherence to care. This shows that stigma screening tool with psychoeducation may improve patient engagement in treatment. However, a larger and a long-term studies are recommended for future study. Implications of this project in practice are the practice implications. Nurses have the responsibility to provide quality care for their patients, and the early identification of stigma can help improve patient engagement in care and deliver quality care to the patients. Patients can benefit from stigma awareness or the use of stigma tools and the initiation of psychoeducation by adherence to care, preventing hospitalization, and improving the patient well-being and safety overall. On a system level, the supports of equality and stigma-informed care can benefit, can improve the patient access to care and improve their overall well-being. Overall, the self-stigma screening tool, along with psychoeducation, were associated with 20% increase in adherence to care favoring the intervention group. Even though it was not statistically significant, but clinically it is a positive trend to improving patient care. And that's what this project was about, to see if there will be some improvement. For future recommendation, a larger, longer, and prospective studies are recommended. The completion of this DMP project or program has strengthened my skills in evidence translation, data analysis, systems level thinking, and it has prepared me to lead evidence-based quality improvement initiatives in the healthcare settings. These are my references, and thank you so much to everybody, all my instructors and my chair. Thank you for imparting me on this journey.